Okay guys, now we're going to look at chapter 23, which focuses on the respiratory system. So when we're looking at the respiratory system, it cannot work on its own. It's going to have to use the cardiovascular system with it. The respiratory system brings oxygen into your body and removes carbon dioxide. However, to get it to your tissues, you're going to have the cardiovascular system take it there. Remember, the oxygen is going to bind to the hemoglobin, and that's how it's going to take the oxygen to the tissues and then bring the carbon dioxide back to the lungs. So the respiratory system cannot work alone. And if you'll notice, most of the systems we talked about can't work alone. They are connected and interconnected with other systems, and these two especially have to work together. So when you look at this, the cardiovascular system is responsible for transporting our oxygen and carbon dioxide in the blood. It's going to do that between the lungs and the tissues. The respiratory system is going to do the gas exchange. It's going to perform the exchange where it's going to take oxygen in and allow it to diffuse into the blood, and it's going to diffuse carbon dioxide out of the blood, and then we breathe it out. So this is where the gas exchange is actually going to happen with the environment and our blood. There's three basic steps to this process of respiration. The first is called pulmonary ventilation. This is what we call breathing. Okay, pulmonary ventilation is what we call breathing. It's the inhalation, taking a breath in, and the exhalation of letting it out. That's what we're talking about with pulmonary ventilation. That's also why when you have breathing issues and you get put on a ventilator, they're doing the breathing. The machine is doing the breathing for you. We then see, once we get the air into our lungs, we need to do external respiration. This is also termed pulmonary respiration. In this particular step, you're going to see an exchange of gases that happens between the alveoli in the lungs, okay, that's the special structure in the lungs, with the blood, okay, with those capillaries that are coming in contact with the alveoli, so you're going to see a gas exchange take place. In this particular gas exchange, oxygen is going to move into the blood and carbon dioxide is going to move out. Remember, we talked about how chemicals like to move from high concentration to low. The blood coming into the lungs now is low in oxygen, high in carbon dioxide. So oxygen is going to be high in the lungs, moving into the blood, so the blood gains it, whereas the carbon dioxide is high in the blood, and so it's going to move to the lungs so that we can breathe it out. This is what we call external respiration or pulmonary respiration. The third type, or the third step, is internal respiration. When we look at internal respiration, this is the tissue respiration. This is going to happen between the blood and the tissues. And so we're going to see an exchange from the blood capillaries and the tissue cells where the blood's going to deliver the oxygen, okay, because blood's high in oxygen here. It's going to move the oxygen to the tissues, and the carbon dioxide is going to move into the blood. Okay, that way the blood can take it back to the respiratory system and we can get it out of the body. So the respiratory system is actually part of waste removal. It's removing the gas waste that we produce called carbon dioxide. Now, one thing to note about the respiratory system, not only does it help with breathing and providing gas exchange, the respiratory system also allows you to produce sound. If you didn't have air moving across your vocal cords, you would not be able to speak or make sound, and so that helps with the respiratory system. Also, your sense of smell is part of the respiratory system because your nose is part of that as well, and it helps regulate your pH. We'll talk a little bit more about this in chapter 27 when we look at electrolytes and pH balance, but carbon dioxide, when it's carried in the blood, is a little bit acidic, and so because of that, it can also adjust the pH of our blood. Alright, so guys, in this diagram you can kind of see how this gas exchange works. Of course, pulmonary ventilation isn't on here because we know we're going to breathe in and out, but once we get the air in, you're going to see that gas is going to diffuse into the blood here. That means oxygen's going into the blood, and the blood's going to then transport it to the cells where the oxygen will go to the cells. At the cell side, the blood's going to pick up the carbon dioxide, and then it's going to bring it back to the lungs where it's going to diffuse into the lungs so that we can breathe it out. So in this particular picture, it's showing you both external respiration and also internal respiration, and blood is the link between the two. So why is getting oxygen to the cells so important? Well, the reason is our cells do a process called cellular respiration. You may recall this back from Anatomy 1, but also maybe in general biology. Cellular respiration is the metabolic actions that your cells take in the mitochondria, okay, of your cells, where it's going to take the sugar, the glucose you take in, plus the oxygen, and it's going to produce carbon dioxide and energy. And so the whole point of that is that the oxygen needs to be there in order to maximize the conversion of our food into the energy of ATP that our cells can actually use. So this is why getting oxygen to our cells is so important. If either system, the cardiovascular or the respiratory system, fails in any way, it's going to affect the body. And the first thing that's going to happen is we're going to see that there's going to be oxygen starvation to the cells. And this can be a big deal if this oxygen starvation is to the brain, because within 4 minutes of not getting oxygen to your brain, you have irreversible brain damage. Not only does the blood carry the oxygen to your cells, we see that there's also a buildup of waste products that will happen because we're not able to either carry it by the blood or breathe those waste products out through your lungs. We are going to have a buildup. This can cause rapid cell death eventually, because not only are you not getting the cells the good stuff, the oxygen, you're not taking the bad stuff, the carbon dioxide, away. Okay, so cells can die very rapidly in this process if either of our systems go out. This is why when you go on a scene, or the first things you check on a patient is what they call the ABCs. You look at their airway. Is their airway opened? Okay. B is, are they breathing? Okay. And then C, is there circulation? Okay. That's why we do that. So when you do CPR, you're doing these two things. You're breathing for them. That's the respiration side. And then when you do the compressions, you are doing the cardiovascular side of circulating the blood. Okay. So it's doing both of these processes so that oxygen can continue being supplied to the body, even though their own body may not be doing it for them. All right, so when we look at our respiratory system is structurally divided into two main areas. Okay, it's the upper respiratory and the lower respiratory tract. Now, you may have heard about this because you may have gone to the doctor before and the doctor's told you that you have an upper respiratory infection. This is going to be the upper part of the respiratory system. However, if you have a lower respiratory infection, it's going to be deeper, okay, in the respiratory system. So there are the two distinctions when we talk about them anatomically or structurally. So the upper respiratory tract consists of your nose, your pharynx, which is your throat, and any associated structures that are above the larynx. And the larynx is right where your voice box is, where you can feel that vibrating when you talk, okay? The lower respiratory tract includes the larynx, the trachea, which is a little deeper, the bronchi, and the lungs. So it's the lower part that's deeper inside of your body. So this is how we can divide the system structurally. On the other hand, we can also divide the system functionally. If we divide the system functionally, there's two main zones or two main functions that this system does. There's a conducting zone, which is going to conduct air in and out of the body, and there's a respiratory zone where we're going to see the gas exchange take place. So the conducting zone, the whole point of it is to help filter, warm, and moisten the air that you breathe in. Okay, so it's going to moisten it, it's going to warm it, and it's going to filter and hopefully get out any like dirt, pollen, invaders that could get down in that lower respiratory system. It's going to then conduct the air down into the lungs to the area that's called the terminal bronchioles. Okay, at the terminal bronchioles, anywhere from the terminal bronchioles up are part of the conducting zone. Okay, when we reach the terminal bronchioles, we see that the function changes. It's going to go into what we call the respiratory zone. This is within the lungs, and this is where the gas exchange takes place. This is going to include the respiratory bronchioles, the alveolar ducts, the alveolar sacs, and the alveoli. This is where those capillaries are going to wrap around, and we're going to actually see gas exchange. Right? Now, this is a lot of kind of new terms coming at you right here, but as we go through this presentation, you're going to see each of these structures. Okay, so this particular picture that's kind of showing you the upper versus lower respiratory system is found on page 841 in your book, and we are going to start at the top talking about the nose first. The nose has several features to it. The first is the external part of your nose. It's this part right here. It's made out of bone right here with your nasal bone. Hyaline cartilage, it's the part that can move, and of course the skin that covers it. It is lined with a mucous membrane on the inside. This mucous membrane is going to help with capturing odors so that you can smell, but also capturing things that get into your nose like pollen, dirt, things like that. In your nose too, you also have external nares. These external nares are going to be your nostrils, and they're the two holes that you have leading up into the inner part of your nose. So now let's move into the inner part of your nose. On the inner part of your nose, you have the nasal cavity. This is the space between the internal nose. Okay, it's going to be lined with ciliated mucous membrane. The whole point here with the cilia is to help move or capture anything everything that gets in there and then get it out. This may be what tickles your nose that causes you to sneeze or something like that. We also see that you have your nasal septum. This is a vertical dividing wall right here, which is going to divide your nose into a right and left side. Okay, that way you have right and the left side. If somebody was to have a deviated septum, they have a broken nose. So their septum is off, and so it can actually plug up both sides, which could hinder breathing. We also see that there's a front portion of the nasal cavity that's going to be called the vestibules, the opening where we're going to bring air in. At the back of the nasal cavity, you have what we call the internal nares. This is going to open into the pharynx, which is the throat. Okay, so this is what we would call the nasopharynx because it opens up into the throat. We also see that you have some paranasal sinuses. Paranasal sinuses are located right here on each side of your nose. They're openings in the bone and they're lined with mucous membrane. The whole point of them is to help drain your nasal cavity, but they also help resonate whenever you speak and make sounds, so that it gives you a certain tone. That's why when you have like a sinus infection and these are clogged or your nose is clogged up, you sound different, because this whole thing is supposed to help resonate with your voice and gives you that particular tone of voice. Okay. Now, the main function of the nose, we've looked at its structure. The main function of the nose is adapted for warming and moistening the air as well as filtering it. Okay, if you'll recall back when we looked at the facial bones in Anatomy 1, there were the nasal concha, which were like swirls inside the nose. This is where air, when it comes in, it's going to swirl through those and it's going to help moisten it and also warm the air before it goes down into your lungs. We also see that it's going to receive the olfactory stimuli here, where we're going to be able to smell, where your sense of smell is located. And the nose is also again involved in speech, because if you plug up your nose or it's stuffed up, you do sound differently. Okay, so that's going to help you with speech. All right, so the next area we're going to look at is the pharynx. The pharynx is known as your throat. It's a muscular tube that's lined with a mucous membrane. It has three main parts to it, and you can see them here. They're color-coded. The first one is this yellowish structure, and it's the nasopharynx. It's the superior part of the pharynx. It's found behind the nose, okay, behind your nasal cavity, and it is lined with ciliated mucous membrane, again, to help capture anything that might be getting into the area. You also are going to see in this area there's the eustachian tubes. These are the openings into the nasal pharynx that connect to the ear, the tube that connects to the ear. The whole point of them is to equalize pressure within your middle ear. And so a lot of times when you yawn, or if you've gone on if you've gone in a plane and your ears need a pop or something like that, that's this tube that's opening in order to allow the equalization of pressure to take place. On the posterior wall of your nasopharynx, you also have your pharyngeal tonsils, what we call the adenoid, which was talked about in the lymphatic system chapter. The next structure that's part of your throat is called the oropharynx. This is the midsection of the pharynx shown in blue here. This is going to be the area mostly that connects with your mouth. Oro means with the mouth. This is where throat cultures are going to be taken. If you have to go in and you're sick and they want to take a culture of the back of your throat to see if anything's growing, this is where they're going to take it from. This area is a passageway for both food and air. The whole point here is to get food and air through. There's no cilia or in this area, but there still is a mucous membrane. So there's no cilia in the oropharynx. In this area as well is where you'll find the palatine tonsils on each side. Okay, those are the tonsils you can see if you still have them and you open your mouth and say ah. And then you have the lingual tonsil, which is at the base of the tongue. Again, it's located here in the oropharynx. The last section of the pharynx or the throat is called the laryngeal pharynx. The laryngeal pharynx is shown here kind of in a reddish orange color. It's the inferior portion of the pharynx. It continues down as the esophagus, so it eventually transitions into the esophagus. Again, there's no cilia here. There is a mucous membrane. It connects at the front of your larynx or voice box, and it is also a passageway for both air and food. We see a transition though here where a fork in the road takes place, where food should go then down the esophagus and air is going to go down the larynx and trachea at this point when we get past the throat region. So when we look at the larynx, guys, the larynx is also termed your voice box. It sits between your laryngeal pharynx, the lower part of your throat, and the trachea. It's made up of 9 pieces of cartilage. All these cartilage is held together by ligaments. Okay, so over here you can see ligaments kind of holding them together. There's different types of cartilage here. There's what we call the thyroid cartilage. This is going to make up the Adam's apple. Hyaline cartilage plate It's actually two kind of plates fused together, and they help maintain and open your airway, keeping your airways open so they don't collapse. Now, of course, this is not 100% of the time. There are times that they do collapse, okay? So the whole point of this cartilage, though, is to help keep that airway open. However, this cartilage, the thyroid cartilage, is also what's going to connect to your hyoid bone by a ligament. Remember, the hyoid bone is the only bone in your body that's not connected to any other bone. It's only held in place by ligaments, and in this case, this is some ligaments that are helping hold it in place. Another thing that we see in this area of the larynx is called the epiglottis. The epiglottis is a leaf-like flap at the top of the thyroid cartilage. This flap is made out of elastic cartilage, and it's covered with epithelium, and then it's attached to the thyroid cartilage at the front edge. So the whole point of this little leaf-like structure is that when you swallow, when you're swallowing food, the larynx will move up, okay? This whole structure will move up. As it moves up, the epiglottis then closes off the trachea. This is to prevent food and liquid from going into your lungs instead of your esophagus. So remember, I told you at this point there's a fork in the road that's happening. Well, we don't want food to go down into your trachea. So when this happens, the thyroid cartilage moves up, and you'll actually see the epiglottis will cover the trachea. In males, the Adam's apple or the thyroid cartilage is normally enlarged, so when they swallow, you can actually see that move up and down. In females, it's a little harder to see. The next one's called the cricoid cartilage. This connects the larynx to the trachea. These are rings of cartilage just above the top of the trachea, and they form kind of like a C. Okay, so they're like a C, and they sit this direction, all right, because behind the C, back here in the back, is where you're going to actually have the esophagus running, all right, and we don't want the esophagus to be pinched, but we don't want our airway collapsing. So the C is facing this way to keep our airway open. However, if the airway does collapse and they can't get a breathing tube down in this area because these rings have collapsed, this is the area where you would perform a tracheotomy, where they would have to cut through this area of the cricoid cartilage, and then that's where they would put the tube, or if you've seen in movies before, they have the only thing they have is a pin, and they'll put it in there to help with breathing. Okay, so this is where a trach would end up going here if they cannot do a normal breathing tube. Now, the larynx also contains 3 additional paired cartilages. These are going to help support the vocal cords, which allows you to speak. This is why, again, it's the voice box. So let's take a look at these extra sets of cartilage that we call the vocal folds. With the vocal folds, you have 2 pairs. One's called the false pair, and the other's the true pair of vocal cords. The whole point of these cords are to produce sound, and they do this by vibrating back and forth as air moves across them. They are attached with elastic ligaments, and they can stretch the vocal folds really tight if we need to make a high-pitched noise, or they can be more relaxed if you make low-pitched noise. Okay, so they're going to move in different ways depending on what kind of sound you need to make, okay, and what tone you're going to give off. Laryngitis is the inflammation of these vocal folds. It makes it where they're so inflamed they can't vibrate properly. Therefore, you'll have a hoarseness or even a loss of your voice completely if they are inflamed enough, if they are swollen enough. Now, the lower portion of the larynx is lined with ciliated mucous membrane. The cilia is here again to help move up any substances that get into this part of the respiratory system. The point of it is it can cause a tickle in your throat, which may cause you to clear your throat or cough. This will move it up into the pharynx, the throat area where you would probably swallow it. So there is some cilia located here too to help sweep up anything that might get down into this area of the respiratory system. Now, the next area we want to talk about is the trachea. This is also known as the windpipe. It connects the larynx to your primary bronchi, which go into each of the lungs. The trachea is made of smooth muscle and some C-shaped rings of cartilage. They're going to continue that C-shaped structure moving down. The reason, again, is if you can notice in this picture, you can actually see the esophagus behind there. That's why they're that C shape, so that it doesn't collapse the esophagus. This area is lined with ciliated mucous membrane, so we're still, if something gets here, we're still trying to move it up and out of the way, okay? That hopefully it won't get down into the lungs. We're still trying to swipe it up and out and cough it out. Okay, the trachea is in front of the esophagus, and a lot of times, guys, the trachea looks like those bendy straws that you get from like souvenir cups. So if you've gone to Six Flags or any kind of amusement park where they have the bendy straw, or that kind of looks like an accordion, that's similar to what the trachea would look like. It's going to be a harder structure because, again, we don't want it to collapse. We don't want it to break down. All right, it's not just made of soft tissue. It's made of this hard cartilage to help keep it opened. Okay. Now, the trachea is going to lead into an area that we call the bronchial tree. So in this picture, you're going to see why it's called the bronchial tree. The bronchial tree is kind of an upside down tree. The main trunk or base is the trachea, which we just talked about. It's then going to branch into what we call the primary bronchi, the first set of bronchi. These are going to be consisting of smooth muscle and C rings of cartilage, still lined with ciliated mucous membrane. And we're going to have one going into each lung. Okay, so it's the primary bronchi, one going into each lung. This primary bronchi, which is represented with a 1 and a degree sign, is going to branch into the secondary bronchi. The secondary bronchi is going to branch even a little further. So the right lung is going to have 3 secondary bronchi, which are also called lobular bronchi. The reason they're lobular is because the right lung has 3 lobes to it. It's a little larger. The left lung only has 2 secondary bronchi because it only contains 2 lobes. Now, the reason the left lung does not have an extra lobe is because the heart sits a little bit towards the left side. So that is why it's a little bit smaller than your right lung. The secondary bronchi then are going to branch into the tertiary bronchi. The tertiary bronchi are also known as the segmental bronchi. There are about 10 tertiary bronchi in each lung. So if you'll notice, it goes primary, secondary, tertiary, and as we move down, we get more and more of these. However, their diameter gets smaller and smaller, okay? So we're going from one branch with the trachea, then we're going to go to the primary bronchi, which kind of makes them smaller. Then you're going to have the secondary and then the tertiary. So we're getting smaller in diameter as we move down. These then divide further into what we call bronchioles, which are tiny bronchi. These are going to then branch into what we call the terminal bronchioles. Terminal means the end, okay? So like if you were terminated from your job, you've been fired. It's the end of you working there, okay? When you go to the airport and you find your terminal, that's the last place you should stop before you get on the plane, okay? So it's the last area. So the terminal here, the terminal bronchioles are going to have no cilia, okay? So there's no longer any cilia. We're not moving things up anymore. By this point, if the invader or the dust or the whatever is got down this far, there's no way of getting it back really up. All right. This area is made of simple cuboidal epithelium, and they are going to contain macrophages. The reason there's no cilia is now we can't get it up, but we are going to still try to protect ourselves by having these white blood cells, macrophages, in the area. The cartilage C rings are going to gradually start to disappear as we move down this tree. The amount of circular smooth muscle, on the other hand, is going to start to increase. So as we move down in the structure of this tree, okay, as the diameters get smaller, the cartilage is going to get less and the smooth muscle is going to become more present. Okay, so that's what we're looking at here with the bronchial tree. Now, if we continue with this, the smooth muscle of this bronchial tree that we're talking about is innervated by your autonomic nervous system. With your autonomic nervous system, remember, this is going to automatically change how you're going to be breathing and how the bronchi are going to react. So during exercise or emergencies like fight or flight, the sympathetic division of the ANS is going to cause bronchodilation. We want to open the bronchi up to get the maximum amount of oxygen into our lungs. However, when the parasympathetic division overrides this during your resting state, we see bronchoconstriction because you're not going to need as much of it. So we're going to kind of constrict off areas that aren't needed because you're able to supply the oxygen just fine to your body. Now, during allergic reactions, okay, when you have an allergic reaction that deals with the lungs, it does cause bronchoconstriction. This can happen with asthma or anaphylaxis or anaphylactic shock. We want to reverse this. And so most of the time if you have asthma, you have an inhaler. The inhaler has a type of steroid in it, and the whole point is to cause bronchial dilation, opening the airways back up. The same thing is going to happen if you use an EpiPen with somebody who has an allergic reaction that's going into anaphylactic shock. The epinephrine is going to help cause bronchodilation. All right, so that's what we're seeing here with how the autonomic nervous system controls the bronchi in your lungs. So guys, we do want to do a quick review of some tissue. The lungs are enclosed and protected by the pleural membrane. Remember that this is another serous membrane. We've already talked about the peritoneum that covers the abdominal organs, and we see that there is the pericardium, which covers the heart. The pleural is going to cover the lungs. It is a double membrane. The outermost part of this membrane is the parietal that's going to attach to the thoracic wall here because it is surrounding the lungs. The visceral pleura is the innermost layer and it's covering the lungs. It touches the organ, which is the lungs itself. The pleural cavity is the opening between the two. This is a tiny space between these two layers, and it is going to have a lubricating serous fluid in here. We call this the pleural fluid. This pleural fluid is really important because, again, as these membranes rub across each other as you breathe in and out, and there's movement, it's to help reduce friction. We don't want friction in there to create heat, and that could cause pain. However, sometimes things can happen to this pleural membrane with the lungs. If air gets into this cavity, you're not supposed to have pockets of air, but if it gets in there from like a wound or from like surgery, we call this a pneumothorax. And a lot of times they put a chest tube in to get that air off there because the air can compress the lung and cause the lung to collapse. If there's blood in the pleural cavity, this is called a hemothorax. This can happen due to trauma, where bleeding's happening into this cavity, or maybe even an infection. Okay, but we've got to get the blood out, so a chest tube gets put in as well to drain the blood. If pus accumulates in this pleural cavity, normally this is going to come along with a pulmonary infection. All right, it's going to make it harder to breathe and things like that. So if somebody has like an extreme case of pneumonia, pus might form in this cavity, and we need to again get it out. But a lot of times getting that out may be through a drain, but it could also be through using different types of medication to help control the underlying cause of the formation of the pus. Now, pleurisy is the inflammation of the pleura. So if the pleura gets inflamed, it can cause friction. Every time you would breathe in, there would be friction. That would be the major symptom of pleurisy would be pain because of the friction that's being caused. We also see that you could have a pleural effusion. This is accumulation of fluid in the pleural cavity. This can happen a lot of times from an infection or cancer if cancer is present, and it starts to put pressure on the lungs so they cannot expand and fill with air as well. So it's going to hinder breathing. All right, so this is just giving you a kind of a review of the pleural cavity, the pleural membrane, which is important because it's covering the lungs. Now, going back to the whole idea of the bronchi, we now want to kind of look at we're moving away from the conducting zone and going into the respiratory zone. We have what we call the bronchopulmonary segments, which are found in your lungs. This is a segment of lung tissue which is supplied by one of your tertiary bronchi or bronchus. Each bronchopulmonary segment is made up of many small compartments, and these compartments are called lobules. Okay, these lobules are going to contain a number of things. Okay, so you can see in the picture over here, it's going to contain a lymphatic vessel. It's going to contain an arteriole, that's the tiny artery where we're going to be bringing the blood towards the lungs. It has a venule, which is going to take the blood away, and then the terminal bronchiole. The terminal bronchiole has lots of smooth muscle, no cartilage, no cilia. The terminal bronchiole is where we're now going to switch gears from the conducting zone to the respiratory zone, and we're going to allow gas exchange to take place. This is again though why the blood vessels are located here, because they're bringing the blood into the area for the diffusion. Now, each terminal bronchiole branches into microscopic branches that we call the respiratory bronchioles, which branch into several what we term as alveolar ducts. Okay, so you can see it here, it's branching into the alveolar duct. Each alveolar duct bulges out to form several alveolar sacs. Okay, each of these sacs contain alveoli, so each of these individual kind of balloon-shaped structures are called alveoli. Now, each alveolus is made up mostly of simple squamous epithelium. So if we recall back from the tissue, simple means one layer, squamous means flat. So this is a flat surface, so diffusion can happen very, very easily. So this is going to be found in this area. These simple squamous cells are called type 1 alveolar cells, and they are going to be the site of gas exchange. This is going to be where the blood capillaries come in contact, and we're going to see the diffusion between the blood and the tissues of the lungs. Now, some of the alveolar cells are going to be a little bit larger. They're still in a single layer, but they're cuboidal. They're more the cube shape. They're larger. They're not going to allow for diffusion as much. Their role is actually to secrete alveolar fluid. This is for moisture and lubrication. This is so that these sacs, as they expand and then they go back down and contract when you breathe out, they don't collapse on themselves. All right, we want it to be able to deflate, but we don't want it to deflate so much that it collapses and sticks to itself so we can't get air back in it. Okay, it's kind of like when you've opened a package of balloons, and some of them you can blow the air in very easily, and when you deflate them you can still see that there's a structure to them. They're not stuck together. Others, if the inside has been glued together, you try to blow air in it and it won't blow the balloon up. We don't want that to happen in our lungs. We want air to be able to move freely in and out. So this is going to secrete a fluid that allows for this. The alveolar fluid contains also a substance called surfactant. The surfactant is a phospholipid. Okay, it's made out of a lipid, and it prevents the collapsing during exhalation when you breathe out. So it's there to prevent that. It's kind of got an oily substance so that they don't stick to each other. There's not that collapsing of the lung. Again, a lung can collapse, and a lot of times it collapses if surfactant's not being made, if there's an issue with these type 2 cells of the alveoli, but it could also be due to trauma or any of those issues we looked at with the pleural cavity. Also, guys, this picture that you see here is located on page 854 in your book. So now let's talk about how breathing and this gas exchange actually works. In order to understand why these gases move the way they do, we need to talk a little bit about some physics. And when we're talking about the physics, we're going to look at some laws that deal with gases. The first law we want to look at is Boyles Law. Boyles Law applies to a container with flexible walls. Well, this applies directly to our lungs and our thoracic cage. They're flexible and they can move in and out. And we can see that because when you take a deep breath in, we see the chest expands. It's flexible. When you breathe out, it goes back down. So we see that that is the case here for your thoracic cage. Now, the whole point of Boyles Law is it says that the volume and pressure are inversely related, meaning that if pressure increases, volume decreases. Okay? If pressure decreases, volume increases. So they do the opposite. If one is high, the other is going to be low, and vice versa. That is what Boyles Law is stating. And you can kind of see that here in the picture. When the pressure is 1, you also have 1 liter of volume. However, when the pressure goes up to 2, we only have a half a liter of volume. It halved it. It went down. All right. And so when we see this, this is what it's talking about with volume being inversely proportional to pressure. So let's talk real quick about how we breathe in and how we breathe out. So pulmonary ventilation with breathing, when we breathe in, we can call this inspiration or inhalation. This is bringing air into your lungs. Now this occurs when alveolar pressure, the pressure inside your lungs, falls below atmospheric pressure, which is the pressure out here in the air that we breathe. Okay, so when the pressure inside is lower than the pressure outside, we see that there's going to be a contraction of the diaphragm. The diaphragm is the muscle that separates your thoracic cavity from your abdominal. It's going to push down. As it pushes down, okay, and the external intercostal muscles are going to pull out, we see that the size of your thorax is going to start to increase. Okay, so it's going to increase. This is going to decrease the pressure even more. So as the pressure decreases more in the lungs, it allows for the air to move in. Because remember, when pressure decreases, volume should increase. So it actually draws the air into the lungs. So we have a lower alveolar pressure. Air moves down its pressure gradient from high pressure to low pressure, and it gets pulled into the lungs. Okay, that's what happens when we breathe in. Now, we can actually force this even more, where you can take more air in. It's called forced inspiration, but additional muscles are needed to do this. We can't just use the external intercostal muscles of our ribs and our diaphragm. You're going to have to use your sternocleidomastoids, which are the muscles here, to elevate your sternum, the scalenes, which are on the upper ribs, and also the pectoralis minors that are going to help elevate the 3rd and through 5th ribs. And so when we do this, if you're just taking normal breaths, you're breathing normally, only your external intercostals and your diaphragm are working. But if you want to take a really deep breath, let's say you're about to jump into a pool of water and we want to hold our breath, you want to take a really forced breath, and that's when you'd go And you're going to use all those muscles to draw that air in, okay, as much as possible. That's forced inspiration. All right, now let's talk about expiration or exhalation. This is moving air out of your lungs. So again, it's going to deal with pressure and volume. This occurs when the velar pressure inside is higher than atmospheric pressure, so the air is going to get pushed out. So we see the diaphragm, it contracted. Now we're going to relax it, and so it's going to decrease the volume. Since it decreases the volume, we're going to see an increase in pressure. We also see that the internal intercostals between your ribs are going to bring and decrease the size of your thorax or your thoracic cavity. All of this is going to decrease the volume, increasing the pressure so that the air gets pushed out. Because now the pressure inside my lungs is higher than the pressure outside, and the air is pushed out. Again, though, we can force more air out through forced expiration if we use some additional muscles. We can use the internal intercostals even more, which can pull down on your ribs, but you can also use your abdominal muscles. If you use your abdominal muscles, they compress the abdomen, which pushes the diaphragm up even further, making the volume even less, which pushes more pressure out. This happens sometimes, like if you think somebody's going to punch you in the gut or something like that, and you breathe out like that, or if you're pushing on something, you have that forced expiration, you're using those muscles, okay? And so you're using extra muscles to force extra air out of your lungs. Now, in your textbook, it talks about different breathing patterns. The first one we see here is eupnea. That's just normal breathing. Dyspnea is labored breathing, so you're having a harder time breathing. Tachypnea, we talked about tachycardia being fast heart rate. Tachypnea is rapid breathing. Coastal breathing is more shallow breathing because you're only using your intercostal muscles. You're not using the diaphragm very much. Diaphragmatic breathing is deeper breathing. If you've ever taken singing lessons before or been in a choir or something like that, the instructor might say, hey, you need to breathe through your diaphragm. What they're telling you is you need to be using all those muscles to the best of your ability so that you can hold notes longer, you get more air, things like that. Now, these different patterns of breathing are produced by different combinations of respiration muscles. So it depends on which muscles are actually being activated and which ones aren't to how much breathing is going to take place. So when we're exercising and your sympathetic nervous system takes over and you're a little bit out of breath, you may have tachypnea because you have other muscles that are going to be working to get air in and out quickly. This may also be more coastal breathing. Your trainer may tell you, hey, come down and take some deeper breaths. That deeper breath is going to allow you to bring in more oxygen than those more shallow breaths. So a lot of this is going to still be controlled by that autonomic nervous system, but it can change how your breathing does take place based on which muscles become activated. Now, there's also some modified respiratory movements that are talked about in your book. These are talked a lot about. There's a table in your book on page 861. It's table 23.2. Please take a look at it. We use modified respiratory movements to express emotions. Okay, sometimes you'll have that if you're a parent, or you may be the child that does this or the person who does that. When somebody tells you to do something and you sigh real big and you go, that's a modified movement of the air. We also see coughing. We clear our passageways a number of ways by coughing and sneezing. This is to clear foreign particles out of the throat. We also see sneezing. Sneezing is a stimulation due to an irritation in the nose, and so it changes how you're going to push the air out with the through the nose. Yawning. Now, guys, the exact stimulus of yawning is kind of unknown. We're not really sure why we yawn, but it does accompany drowsiness. So when you're tired, you see that you yawn more. Fatigue, again, can cause yawning. But also, yawning is contagious. When you see somebody else yawn, it can cause you to yawn. All right, and so that's, again, why we're not really sure what causes that stimulus. We also see hiccuping. Hiccuping is going to be a spasm of the diaphragm. The diaphragm itself actually spasms, and when it spasms, it's due to an irritation of a GI nerve. A lot of times it happens when you've eaten something that irritates that nerve, and it causes those hiccups. Sometimes hiccups last for a long time, sometimes a short time, but it is a spasm of your diaphragm. We also see sighing, sobbing, like different types of crying, whether it's like a really bad, like, your whole body shaking type of cry versus just a simple cry, or even laughing. These are all modifications of breathing. Everybody kind of laughs a little bit different. Some people, they laugh where they don't make any sound. It's like they're holding their breath. Others, they make lots of noise when they're laughing, but it causes differences based on how they're breathing. We also see that there's what we call the Valsuvia maneuver. This is forced expiration without exhaling. It's when you have that that you're doing. A lot of times this maneuver is used when you're straining to get rid of a bowel movement. All right, when it won't go and you are using all those abdominal muscles and all to try to help push it out. That's what we call the Valsuvia maneuver. All right, the next thing I want to talk to you about is the pulmonary air volumes and your capacities. How much air can you actually hold in your lungs? There's a number of ways that we actually can measure this, and the way that we measure these volumes and capacities is using a spirometer. Spirometers at the doctor are going to be a little different than spirometers that you might have access to in the lab, but there is a video that's located in your lab over the lungs that shows you a type of respirometer where we use the computer. Now, when we use a respirometer, we can actually create a chart or a diagram of these different types of breaths. And I'll show you the diagram after we go through like the definitions. The first definition here is your tidal volume. Your tidal volume is the volume of one normal breath. It's you breathing in and breathing out, but it's your normal breathing. And this is approximately 500 milliliters, okay? And so about 500 milliliters is what you breathe in when you're just at rest, breathing in and out normally. Now, your inspiratory reserve volume is the additional air you could take in, all right, because there's extra space in your lungs and you could take in more air. That's when you do that forced inspiration where you're going to take that breath where you take a deep, deep breath, okay? So instead of just 500 mLs, you can actually take in more extra, which is about 3,100 milliliters. Okay, so it's a lot more that your lungs can actually hold, but they're forced. It's when you forcefully breathe in. Now, your expiratory reserve volume is the additional air which you can force out. Normal breathing, you still have air in your lungs. If we want to force that extra air out, we're going to see that you're going to have to actually breathe it out forcefully, where you so you're breathing it out forcefully. You can breathe out about 1,200 more milliliters. But guys, if you notice, you can breathe in a whole lot more than you can breathe out. There's a reason for this. Some of the air never leaves your lungs, and this is called the residual volume. The residual volume is the air which cannot be forced out, and it's about 1,200 milliliters. The reason is, remember we talked about how we don't want those alveolar sacs to collapse on themselves where the lungs stick to each other. Okay, this also helps with that. If there's at least a little bit of air that's left in each of those sacs, it's going to make sure that they don't collapse. All right, so there's a residual volume of air that stays in there to help make sure that these alveoli do not collapse on themselves. Now, based on all this, you can actually calculate a lot of your capacities if you have these different numbers, as long as you have two of these numbers. All right, so when we're looking at the chart in a minute, you're going to see that if we add tidal volume to your inspiratory reserve volume, you can actually see what's your capacity of breathing in. If you add your tidal volume to your expiratory reserve, it's what is your capacity of breathing out. Okay, so we're going to be able to add these up very easily when we look at this. Okay, also, we can also calculate the minute volume of respirations. In order to calculate this, you're going to take your total volume of air that you take in per minute. So what you're going to do with this, so it's the total volume of air you can take in per minute, and you can calculate this. You're going to calculate how many breaths you take in a minute. Okay? So you'll sit there and you'll time yourself. You can have a timer and you just breathe normally. Don't breathe labored or don't hold your breath. Just breathe normally. Count how many breaths you do in a minute. You'll take that number and then you'll multiply it by your tidal volume. Guys, we are going to use our tidal volume as being 500 milliliters. All right. Once you have that, that can tell you how much air you breathed in and out in 1 minute. That's what we're looking at with your minute volume of respiration. Now, of course, this could increase if you were exercising. You may have more respirations. If you were sleeping, you might have less because you're more relaxed. It just depends. Okay, and so it depends on what kind of activities and how much of that tidal volume is, what that tidal volume is at that given time. So let's take a look at it looking at this chart, okay? You need to be able to read this chart. In here there's numbers on the side, so you should be able to go through and do some calculations if you're given a chart like this. At the beginning here, you see those smaller waves. Those are going to be your tidal volume. So you're going to breathe in, you're going to breathe out. You're going to breathe in, you're going to breathe out. And these are just normal breaths, okay? And they are between their 2,500 and 3,000 mL. So that if you subtract that, 3,000 minus 2,500, you get 500. So that's where your tidal volume here is 500 mLs. Then you're going to notice that we're going to go through the process of taking a very deep breath. Now, we're looking on this particular side of the graph. You're going to take a deep breath in, and you see that the chart goes way up. That's your inhalation. And then you're going to breathe out, and then you're going to force the extra air out, and that's the exhalation. And then you're going to go back to your normal breathing. Okay? And so when you add these up, you can start to see that you can add different things. So your inspiratory capacity, how much you can breathe in, is going to be your tidal volume plus your inspiratory reserve. Okay? What we call your functional residual capacity is going to be your expiratory reserve plus your residual volume. Okay, you see in the chart here where you can see the two things. If you move over, you're going to see that you can see your vital capacity. Your vital capacity is your inspiratory reserve plus your tidal volume plus your expiratory reserve. So we're adding 3 of the 4 numbers together. The last one's adding the whole chart together. If we add the whole chart together, that's called your total lung capacity. And for most people, their total lung capacity is about 6,000 milliliters, okay, of air. 6,000. Now this can change depending on different things that the individual is going through. If the individual has like pneumonia, this capacity will be lower. Okay, their total lung capacity will be lower because they're going to have a more difficult time getting air in or pushing the air out. If they have something like emphysema, the same thing can happen. If they have asthma. So we see that this can change depending on what that individual is dealing with. But this is just showing you how you could measure these, and if you're given a chart like this with numbers, you should be able to calculate these. It's simple addition or subtraction that's taking place. So now, once we get the air into the body, okay, once we breathe in and we get oxygen in, we need to see the exchange of oxygen and carbon dioxide take place. Again, we're going to see some physics laws that apply. The first law is called Dalton's Law. Dalton's Law applies to a mixture of gases. Guys, the air we breathe in out here is not 100% oxygen, okay? It's actually only about 21% oxygen. And so there's other gases that are in the air, including carbon dioxide, nitrogen, phosphorus. There's a lot of other stuff that's in the air, okay? And so Dalton's Law says the pressure of each gas is directly proportional to the percentage of that gas in the total mixture. Okay, so when we add the nitrogen to the oxygen to the carbon dioxide to the phosphorus, if we add all the gases together, then we get our total pressure. Okay, the pressure that we want to focus in on, though, is the oxygen pressure, because that's what we need to get to our tissues. So if we look at the example here, you have your oxygen. Oxygen is 21% in the atmosphere. So if we're going to look at the pressure of oxygen, you're going to take that percentage, which we convert to a decimal, which is 0.21, and you're going to multiply it by the pressure that is in the atmosphere, which is 760 millimeters of mercury. Now, I don't expect you to memorize this, but the whole point is that you could calculate this if you know the percentage and you know the pressure in the atmosphere. So out here in the atmosphere, oxygen has a pressure of 159.6 millimeters of mercury. So what happens with this is that each gas is going to diffuse across the permeable membrane from the side where its partial pressure is greater to the side where the partial pressure is less. Guys, this is just like simple diffusion. They want to move from a high pressure to a lower pressure. Okay, so the greater the difference, though, the more the pressure difference is, the faster we're going to see that movement take place. The faster the diffusion is going to happen. Since there is a high partial pressure of oxygen on the lung side of what we call the alveolar capillary membrane, that's what the AC stands for, the alveolar capillary membrane, oxygen is going to get moved from the alveoli in the lungs to the blood. We're going to see it move that direction. Since the pressure of the carbon dioxide on the blood side is higher, okay, on the alveolar capillary membrane, carbon dioxide is going to move into the lungs, and that's what you can see happening here. There is going to be that exchange due to the pressure differences. Oxygen is going to move from high to low, going from the lungs to the blood. Carbon dioxide is going to move from high to low from the blood to the lungs. Okay, and so we see the difference that takes place due to Dalton's law. So when we look at Henry's law, we can see that like carbon dioxide actually dissolves better in a liquid than oxygen does. This is why oxygen has to travel on the hemoglobin. That we'll talk a little bit more about again in a little bit. But we can actually see this really well in a Coke or in a pop like Dr. Pepper, Pepsi, Coca-Cola, Sprite. When you open up the container and you hear that psh, and it starts bubbling, that's actually carbon dioxide. They put carbon dioxide in there to carbonate it, and so that way it gives it that certain taste. However, and guys, so carbon dioxide will slowly leak out, and that's why the Coke will eventually go flat, okay? Because it doesn't stay in there forever. It just can stay in there better than oxygen can. So carbon dioxide is 24% more soluble than oxygen, so it's easier for it to move into that liquid than oxygen does. Now, because of this, sometimes individuals who have a hard time breathing, like because of Henry's law, they may be put on a nasal cannula, you know, the little part that goes into their nose that hooks up to an oxygen tank. This will increase the pressure of the oxygen they're breathing. So instead of breathing 21% oxygen, they may be breathing 100% oxygen. This is going to cause that movement to change and allow them to get that oxygen a lot easier. Okay, and so if the lungs are having a hard time due to like a disease like emphysema, COPD, things like that, we may see that we need that extra help, and that oxygen tank increasing the pressure of oxygen will help with that. Okay, so if we go back to the beginning where we were talking about the different types of respiration, let's look at the external or pulmonary respiration and how the gas exchange takes place. Oxygen and carbon dioxide is going to diffuse down their separate pressure gradients. So deoxygenated blood that comes from the heart to the lungs is low in oxygen, high in carbon dioxide, and it's coming from the right ventricle through the pulmonary trunk and arteries. Once it comes in contact through the capillaries with the alveoli contains high oxygen and low carbon dioxide. So the blood ultimately gains oxygen and loses the carbon dioxide, and the blood then is going to return to the left atria through the pulmonary veins. Then it's going to be pumped by the left side of the heart to the rest of the body, and the gas exchange has taken place. This allows the lungs then, when you breathe out mostly carbon dioxide. So when we talk about this gas exchange, in order for this oxygen and carbon dioxide to move in the proper direction, there needs to be a steep enough pressure gradient. Okay, we have to actually see that there's enough difference between the oxygen in the lungs and the oxygen in the blood in order for it to move. Okay, if it's only a little bit of a gradient like this, it's not going to move very much. And things that can affect this is like high altitude. If you've ever gone into a higher altitude area and had trouble breathing at first, especially if you've lived in an area that's like close to sea level, it's going to be hard for you to breathe because there's less oxygen available. The pressure of the oxygen in the air is less, so it makes it a little bit harder. But guys, this is one reason why athletes a lot of times will train in these areas, because if you live in a higher altitude and you train and exercise in that altitude, you actually produce more hemoglobin, so you can pick up the oxygen better. All right, and so it allows for that to happen, and that will happen naturally given time in that area. We also see that there's got to be a large surface area, so that alveoli is like a balloon, and when it fills with air, it increases the surface area so that it allows those capillaries to come in close contact, allowing for maximum gas exchange. An individual who has lung damage like emphysema, this decreases the surface area. It doesn't let them expand, and so because of that, it decreases the amount of oxygen they can take in. We also see what's important is that there's a short distance. The gas needs to be exchanged over a short distance, so you see the capillaries coming in almost direct contact with the alveoli so that it's a very short distance. We also see that the structure of the alveoli and the capillary are simple squamous epithelium. It's so that they are in close contact. Now, if an individual has like a lung infection, like with pulmonary edema, like with pneumonia, we will see that fluid will build up between these two areas and it separates them. Again, diffusion is not going to take place as well because the space is bigger. All right, so these are things that actually can influence whether oxygen is going to be moved in the proper direction as well as carbon dioxide. So now we've got the oxygen into the blood. The blood is now being pumped to the tissues. So now let's talk a little bit about that internal tissue respiration. So the exchange of gases that happens here. This is going to take place between the tissue capillaries and the tissue cells themselves. So the left side of the heart is going to pump the blood to all your tissues. Oxygen and carbon dioxide will still diffuse down their pressure gradients, just like we saw before. However, the blood is now oxygenated. It is high in oxygen, low in carbon dioxide. All right? And the tissues are going to be low in oxygen, high in carbon dioxide. So, how does this move? Well, the blood is going to gain the carbon dioxide because it's going to move out of the tissues, and the oxygen is going to move into the tissues. Okay, the blood loses it. This is why the blood then becomes deoxygenated. It returns to the right side of the heart, and the right side of the heart is then going to pump it back to the lungs so that external pulmonary respiration can take place. So this is a constant back and forth that's taking place in the body. The pulmonary circulation does the external respiration. The internal respiration is going to take place with the systemic circulation that you learned about in the heart chapter. So what affects your breathing and how quickly you breathe? You have some respiratory centers located in your brain. However, they are scattered groups of neurons that are found in your medulla and your pons. So it's not just found in one specific area, but it is still in the brain stem area. There's 3 functional areas that help with breathing. The first is your medullary rhythmicity area. This is located in your medulla, and it's your basic rhythm of breathing. So this is your basic control of breathing. Your expiratory area contains autorhythmic neurons, which helps you with your normal respiration rate. We also have expiratory areas, which contain neurons which are only active during forced or labored breathing, like when you're exercising. You need additional air, additional muscles, but it's going to be there mostly for controlling your basic breathing. On the other hand, there is an area called the pneumotaxic area. This is located, however, in the pons, not the medulla. This sends impulses that limits inspiration and facilitates expiration. Well, why would we want to do this? Well, we do not want to overexpand our lungs. Our lungs are only going to allow so much in. It's kind of like a balloon. If you put too much air into the balloon, what eventually will happen? It will pop. We don't want that to happen. So the pneumotaxic area monitors that. And so even in your labored breathing, when you're exercising or you're in a fight or flight, this area is going to make sure that you do not put too much oxygen in there. Okay, it's going to actually make you breathe out if your lungs get too full. On the other hand, the apneustic area is located in the pons, and if you look at this word, it sounds like apnea. This is going to send impulses to activate the inspiratory area so that you will breathe in the medulla, and it stimulates inspiration and inhibits expiration. This is really important with people who have apnea or children who have apnea. The apneustic area should keep you breathing, even when you're sleeping. Okay, so even when you're sleeping, whenever your breathing gets even more shallow, if this area notices that you're not taking a breath in, it sends an impulse and it makes you breathe in. People who have sleep apnea, though, this area is not working for whatever reason. And so a lot of times they have to be on the machine, and that machine will monitor their breathing and puff air at them whenever they stop breathing or it's too shallow. That puff of air causes them to breathe in. In preemies, like my daughter, they give them medication called Capsid that helps stimulate this area. But it makes the baby real irritable too because it doesn't allow them to be in a deep sleep. Okay, it's like pure caffeine that you're giving the child. But the whole point is in preemies, this area can be underdeveloped. This area may also be the culprit for SIDS, sudden infant death syndrome. We're not really sure how or what happens in SIDS, but the child stops breathing. And so this could be the area of the brain that did not allow the child to register that it needed to breathe, and it could potentially have been the problem. Now, your respiration rate on how quickly you breathe in and out can be modified by a number of factors. The first is your cerebral cortex. Your main part of your brain can voluntarily change your respiration. You can decide that you want to take quicker breaths, and you can make yourself do that. You could hold your breath. All right, the cerebral cortex can help do this. However, holding your breath can only last so long. When you're no longer able to get oxygen, the brain, the apneustic area should trigger you to actually breathe out. This is why you can't hold your breath forever. And if you try for too long, it'll actually make you pass out, and that will cause you to then start breathing again, and your medulla will take over. But we do want this to be helpful. Like if you needed to jump into water, you want to hold your breath to do that. Also, chemical stimuli can modify your breathing. If you have a buildup of carbon dioxide, the carbon dioxide has extra hydrogen ions, which decreases your pH and makes your blood more acidic. Your blood doesn't want to be more acidic. And so because of this, the medulla may cause you to start breathing, changing your breathing pattern. Also, hypoxia will increase your respiration rate. That's the RR. Hypoxia is when you're not getting enough oxygen to parts of your body. Severe hypoxia causes damage to the inspiratory center, though, and this can be a big problem. If the inspiratory center is damaged and it's not getting the oxygen, it can't modify your breathing, which then makes it where you get more hypoxia, causing more damage, and so on. All right, so it's a vicious positive feedback cycle that can cause major problems. We also see that proprioceptors are going to detect increased body movements. When you have increased body movements, you obviously are going to need more oxygen for those muscles that are moving, and so we will see there be an increase of respiration. Temperature, if you have a fever and you're hot, it will increase the respiration. If you're cold, you'll actually see decreased respirations. When you get sudden pain, like a sudden sharp pain in the area, it causes apnea. It causes you to stop breathing. Like you hold your breath because of that pain, but eventually again you start breathing again. Prolonged pain will actually increase your respiration. This is why you see women who are in child labor and they're in that pain for a long period of time, their respiration rate will increase. There's more things that modify or even talks more in detail of these in your textbook on table 23.3 on page 876. So now let's talk real quick about how oxygen and carbon dioxide is transported in the blood. Okay, we know a little bit about this from the blood chapter, but let's take another look. In your blood, about 1.5% of the oxygen you take in is dissolved into the plasma. It actually dissolves into the liquid, and that's how it travels. That's not very much. Majority of the actual oxygen you take in, 98.5%, is going to be carried attached to that protein hemoglobin, HB, that we talked about back in the blood chapter. Oxygenated hemoglobin is called oxyhemoglobin. So it's really important that this particular protein is there. If this protein's not there, you become anemic, which means you no longer are carrying enough oxygen for your body cells. The carbon dioxide, on the other hand, it can travel in more ways than the oxygen. Because it can actually diffuse into the liquid plasma easier, 7% of it can travel in the plasma as a gas, okay? That's still not very much, but it can be transmitted or transported that way. 70% of it is going to be converted into what we call carbonic acid. Now, this carbonic acid is going to be taking this carbon dioxide and adding it to water, like you see here in this equation. This is going to create a carbonic acid, which is H2CO3, which dissociates in water. When it dissociates, that means it turns into that acid, and that's where that H plus comes in and makes it acidic. There is an enzyme that helps do this. This enzyme is called carbonic anhydrase, and we know it's an enzyme because it ends in ACE. Now, 23% of the carbon dioxide is going to be attached to the hemoglobin. The hemoglobin dropped off oxygen, so it has empty seats. It's almost like a bus service or a taxi service, and it's empty. So it's going back to the lungs anyway, so why not pick up some carbon dioxide? So about 23% of the carbon dioxide will actually attach and bind to where the oxygen used to be, and it will travel to the lungs. This is called a carbonohemoglobin because it's got carbon dioxide attached to it. The amount of hemoglobin that's saturated with oxygen is called your SaO2. This is kind of like your oxygen stat. A lot of times we take this stat at the hospital where they'll put the little thing on your finger and they want to see how much oxygen is getting down into your finger to those tissues. Each hemoglobin molecule can actually carry up to 4 oxygen at a time. All right, so it has 4 places that oxygen can combine. It's like it's got 4 seats that could be full. If they're full of oxygen, it's going to be around 95 to 98%. You're never at 100%, okay, oxygen capacity. It's at 95 to 98. When the blood actually returns to the lungs, we're not down to 0. There's not 0 oxygen there. Most of the time, the blood has only dropped off 1 of its 4 oxygens. So there's still 3 oxygens on each hemoglobin. And when it goes back to the lungs, it picks up the 4th again. This allows your stats to stay at 75%. Now, this is important because let's just say you do stop breathing, okay? And because you stop breathing, the individual comes over and they may not know how to do complete CPR, but they can do compressions. As they're doing compressions and they're pumping your blood, when it got back to the respiratory system, it went from having 4 oxygens to 3. Okay, now it didn't get to pick up any more oxygen because you're not breathing, but as it gets pumped back through again due to that circulation and those compressions, it can then drop off another one. Now you're down to 2. So now you're at 50%. Okay, it can go again and then you're down to 25, and then you finally get down to 0. Hopefully by this point you are then getting help with breathing. Either somebody who knows how to do CPR is helping you, or you're getting medical help that's above and beyond just CPR. Okay, so this whole idea of being able to hold on to some of that extra oxygen helps you have an oxygen reserve even when you're not breathing for a short period of time. Okay, so when we look at this, guys, this hemoglobin saturation we're talking about, saturation of O2, is the percentage of heme units in a hemoglobin molecule that contains bound oxygen. So the more that we have bound, the closer we are to 4 on each hemoglobin, the higher the percentage. Now, most of the time we want to be in the 90s. As long as your hemoglobin saturation is in the 90%, you're pretty good. Okay, when it gets into the 80s, it's a little more troublesome, and especially if it gets in the low 80s. Below that point, it's very hard for your tissues to stay viable and all of that, and your brain to get enough oxygen if the hemoglobin isn't being delivered like it should. There are some environmental factors that affect how hemoglobin can carry this oxygen, if it can fill all 4 seats or not. First of all, the pressure of oxygen of the blood, the amount of oxygen available. The less oxygen available, the less they're going to pick up. This is why some individuals who have like emphysema or COPD, they need to be actually on pure oxygen to help this process. Blood pH, the more acidic the blood is, the less likely oxygen is going to be attached to hemoglobin. It has a hard time holding on to that hemoglobin if it's more acidic, and this is why the pH of the blood needs to be maintained very carefully. Temperature can also affect how well you're holding on to that oxygen, and also metabolic activity within your red blood cells. So the higher the temperature, the more metabolic activity, the harder it is for your cells to hold on to the oxygen. All right, and so this is why a lot of times when you're hot or you're exercising, your respiration rate increases because you need to get more oxygen onto that hemoglobin. So guys, if we take a look at this a little closer, as blood flows from the lungs towards the tissues, the acidity does increase. The pH starts to decrease and become more acidic because we're getting closer and closer to the carbon dioxide. This causes a shift where the hemoglobin has a harder time holding on to the oxygen, and it drops the oxygen off. Since it drops the oxygen off, this is called the Bohr effect. Now there's a seat open for carbon dioxide to be picked up. At the lungs, the oxygenated blood has a reduced capacity to carry the carbon dioxide, all right, because the pH is changing again, and carbon dioxide is going to then leave because you're going to exhale it, and the oxygen is going to be able to be bound to the hemoglobin again because we've restored our pH back to normal. This is called the Haldane effect. All right, so these are two kind of effects that happen due to pH changes, whether carbon dioxide or oxygen needs to move in certain ways, into the lungs, out of the lungs, into the tissues, out of the tissues. So in your textbook, guys, there is a section that you need to read. It's page 878 to 881, and it talks about a lot of the diseases and disorders of the respiratory system. These range from asthma to certain kinds of cancers, to SIDS, the sudden infant death syndrome, even severe acute respiratory syndrome, which we call SARS. There's a lot of different ones for you to take a look at, so please make sure that you read over these in your textbook. If you have any questions or concerns about this chapter, please feel free to contact me.